So our next speaker, I'm very happy to introduce Dr. Jami Kinnucan. Jami joined us from the University of Chicago, which is another world-class inflammatory bowel disease program, and it's really been a delight to get to know Jami and have her as a colleague as well as a friend. She really has an incredible IBD practice that she has built at the University of Michigan and has become quite popular with all of our patients. She's academic and has published papers and also gives a lot of talks with patient education. Jami sits on the CCFA's National Patient Education Committee and is a vocal voice in designing a lot of the programs that bring information to all of you. So really happy to have her join our program. She's going to be talking about complementary and alternative medicines. And so with that, I'll introduce Dr. Kinnucan.
Hey everyone, welcome back. It's great to see some familiar faces of patients in the room and also to meet some new people today. I've been challenged with giving a talk about all things complementary, and I don't know if you guys saw the thing that came out initially. Complementary was spelled a little bit differently than we spell it in the medical terms, but complementary and alternative medicine in inflammatory bowel disease is a hot topic, and it's something that I know that a lot of my patients are interested in. I probably say that 80% of my patients bring up something related to complementary and alternative medicine during our visit. I just want to do a sound check real quick to make sure that everyone can hear me in the back of the room. So if you can't hear me, can you put your hand up? All right, I talk pretty loud, and then I'm also pretty close to the microphone, so I think everyone should be able to hear me. And I'm going to get started. So normally in medicine, we start talks with disclosures, just to make sure that you guys understand where I'm coming from. I don't have any financial relationships with any companies that would be related to this talk. So this is just me giving you the data and the evidence with no bias in it. And my bias is that I'm really excited about patient education as well as provider education. So me being here today is I'm excited to teach you guys about what we know in terms of complementary alternative medicine. But also I sit on the National CCFA Patient Education Committee. And this committee is actually comprised of a subset of patients as well. And so if you're interested in getting involved with patient education and having really taking place at the ground to make sure that you guys are getting all of the information that you need from the CCFA, please let me know, because I'd be happy to get you involved in the patient education committee as a patient. It's mainly providers, but we have about 40 patients that are involved in the committee. So I'm going to move on and talk to you about a little bit of the outline of the talk, and I know that you guys all have these slides in front of you. I'm not really going to deviate much from the slides, so the information is there, but I'm going to, kind of give you a little bit more background besides what's written on the slides. So we're going to just briefly touch on traditional therapies that we're currently using in inflammatory bowel disease. I'll give you a brief definition of complementary and alternative medicine. We're going to talk about diet and nutritional supplements, and along those lines goes microbiota, and I really think that Dr. Higgins did a wonderful job reviewing everything about fecal transplants and either the lack of data or what we could maybe have a better patient selection process in terms of finding the right patients to undergo fecal transplants. We're going to talk about exercise and yoga, low-dose naltrexone, cannabis, which I think is probably the most exciting topic to talk about, at least it's what my patients are most excited to talk about in clinic, and then how can you get involved? So I'm going to give you all this information, but then how can you participate both through clinical trials and some upcoming stuff we have at the University of Michigan. So my disclaimer here is that I don't want you to feel that this is a complete, comprehensive overview of all things complementary and alternative in terms of medical therapies outside of our conventional therapies. I really wanted to touch on some of the ones that are more popular, the ones that my patients ask me about. But if I had to talk up here, it would probably be 3 or 4 hours to talk about all the different complementary and alternative medicines. So I really picked some of the more popular ones. So I want to start this talk off by talking about us talking the same language. So often patients feel like providers are either speaking over them or they're not speaking the same language, and sometimes when we're speaking we want to make sure that you really are understanding what we mean when we say mucosal healing. So we all know that in the room, if you have disease or if you have a loved one that has disease, you want the same things, and this is just a small list. You want to feel better, you want to be able to go to school, you want to get married, you want to have children, you want to be able to go to dinner and not worry about where the bathroom is. You want to go to the conference on a Saturday morning and not worry about making it to the bathroom all the way down the end of the hall. And trust me, as providers, we want those very same things. And those are the same things that we talk about in clinic. But I also want to go a step further. If I just made you feel better and I didn't focus on what I know in terms of the data is actually healing your disease, then I think that I'm actually missing an opportunity to really change the outcome of your disease. So mucosal healing is that deep remission. It means that you feel well, and we look at your colon, your small bowel, whether we do an endoscopy, we measure your blood work, we look at stool proteins, and we see that there's no signs of ongoing inflammation. This, we know, is associated with a decreased risk for progression of your disease, as well as a decreased risk for hospitalization and surgery. And these are important things too. While you didn't say that up front, that those are the things that you don't want, I'm sure that many of you don't want to be on steroids, you don't want to be in the hospital, and you don't want to have part of your bowel cut out. So these are important things that we all want. So if I just stopped at making you feel better and didn't ask any more questions, then I wouldn't be doing you justice in terms of helping you with your disease. So this is where we need to make sure that we're speaking the same language. The traditional IBD medicine cabinet. So these are what we consider our conventional-based therapies. Briefly touching on them, over-the-counter therapies, many of you have probably been on them, loperamide, Imodium, fiber supplementation. Those are some of the over-counter therapies that we use in IBD. Antibiotics. So antibiotics were initially one of the first therapies outside of steroids that we used in terms of treating IBD. We don't know that there is a lot of role in antibiotics currently outside of specific types of inflammatory bowel disease and specific complications related to inflammatory bowel disease. It's certainly not a primary therapy, but we definitely use them in conjunction with a lot of our other therapies. Aminosalicylates, so these are the 5-ASA or mesalamine-based agents. They're only approved for ulcerative colitis, and they're meant to only be used in ulcerative colitis. But these are what we consider sort of our first-line therapies for patients with mild to moderate disease. Who's been on steroids in the room? Almost everybody. And so steroids were probably the first treatment that we had in terms of managing ulcerative colitis and Crohn's disease. And while none of us want to put you on steroids, there are particular patients that need to be on steroids for a short term. But we need non-steroid-based therapies. And these are the other therapies that we're going to talk about. And then we're going to talk about some of those complementary alternative medicines as well. So immunomodulator-based therapies, these are your 6-mercaptopurine, your Imuran, your azathioprine, your methotrexates. And then the biologic-based therapies. These are the anti-TNF-based therapies, vedolizumab, which was approved a couple years ago, and then very exciting, and Dr. Govani is going to talk to you about some of the newer therapies, including ustekinumab or Stelara, which was just approved in the last month. I'm going to add a last box here. So these are these complementary and alternative medicines that maybe we should start figuring out how we can incorporate them into our traditional therapies. We're going to talk about other options, including diet and nutrition, as well as low-dose naltrexone and cannabis. Is lymphoma. Is the reason why they don't want to start medication A or B is because of the risk of possibly getting lymphoma. So I just want to make sure, this is some excellent work that came out of Dartmouth. So this is called the 10,000 Patient Project. And it's a really great way to visualize risk. Because just giving you a number or a percentage or telling you what the odds are, even as a medical provider who deals with statistics on a daily basis, I have a hard time visualizing that, and I'm a very visual person. So this is what everyone, if you were on no medical therapy, what your risk of developing non-Hodgkin's lymphoma. So it's about 2 out of every 10,000 people. So obviously there's about 150 people in the room, so the risk in this room would be close to 0. Your risk of being struck by lightning, does anybody know? Or the odds of being struck by lightning in your lifetime over 80 years? Can anyone take a guess? No, it's actually closer to 1 in 13,000. So it's almost near your risk of getting lymphoma. Your risk of actually knowing somebody or being affected by somebody who's been struck by lightning is 1 in 1,000. So that's actually much higher. So you're more likely to know somebody or be almost nearly the same risk of being struck by lightning as you are to get lymphoma at baseline. So then when we look at risks of being on therapy, so we talk about our immunomodulator-based therapies, these are our azathioprines, our Imurans, and our 6-MPs, that risk goes to 4 out of 10,000. So still, it's a very, very rare risk, and when I show you what it looks like in a percentage, it's almost 0, and in most programs that would be rounded to 0, but it does double your risk. So that sounds scarier than what I'm showing you up here, which is not that little red box, just moves slightly. And then for those patients in the room that are on combination therapy, that's the anti-TNF-based therapy within a combination immunomodulator-based therapy like 6-MP, Imuran, or azathioprine, that risk goes to 6 out of 10,000. Depends on the study that you look at, but really we think that that risk is really driven more by the immunomodulator therapy than it is by the anti-TNF-based therapy. So when you look at this in a table, I want you to see what this looks like in terms of your risks. So your risks of non-Hodgkin's lymphoma, whether you're on therapy or combo therapy, is all on the right. Hepatosplenic T-cell lymphoma, which is the number one concern that a lot of the moms that come with their sons to clinic have concerns about their sons being on this, is actually very rare, and it's been in case reports. This is not something that is even on the 0.0002%. Serious infection, so that's what people care about. That's about 4 in 1,000 risk of having a serious infection. That's not death, so it's just a serious infection that's treatable. And then tuberculosis is about 5 in 10,000. And this is really generalizing across medications in general, so it differs with certain therapies. But I want you guys to see this. This risk profile is really, really, really small. Okay, so this is, it helps to put things in perspective, to understand that of course it's scary to hear the word lymphoma, of course it's scary to think of getting a life-threatening infection, but these risks are very, very small, and the benefits of these therapies can't even be matched by these small risks. So what happens if we don't treat your inflammation? You don't want to be on therapy because of concerns about risks of infection or cancer or side effects that, unwanted side effects. Well, missing life events, it's hard to quantify those, but having to delay a wedding, maybe not being able to go to a significant other's important event because you're not feeling well. Progression of your disease, which scares me as the provider the most. I know what your disease looks like right now, but if we don't do therapy, I don't know what your disease is going to look like in 6 months. And we may not be able to use some of our conventional therapies to get you under control. Uncontrolled disease complications, which I'm sure many of in the room have had problems with having complications related to your disease. You've had a stricture, you've had an abscess or a fistula, you've developed colon cancer in the setting of uncontrolled inflammation in your colon. So these are very real risks that are associated with disease. And so it's really important that we get that disease under control. And I know that we're all on the same page, that we all want you to feel better and we all want to control the disease. But I don't know that you knew that up to 70%, and I know that my patients with Crohn's in the room probably know this, but up to 70% of patients with Crohn's disease, at least based on some of the earlier studies, will require at least one surgery in their lifetime. So the therapies that we have that have come out in the last 10 years, this is changing that. We're seeing these rates go down because we're actually able to change the disease so that people don't end up with surgery. Up to 1/3 of our patients with ulcerative colitis that have ongoing inflammation will require surgery. As we know, the newer therapies that have come out will actually have changing this number, but this is based on data before we had adequate therapies for our disease. So these are real risks. So if we put these next to those risks for infection, a 70% chance of requiring surgery or a 30% chance with colitis, I can't compare those risks. So I think it's important just to have that perspective in terms of the disease and what the risks of the therapies are. So what do we mean when we talk about complementary and alternative medicines? It's a group of diverse medical and health systems and practices or products, so it's not all just medicines, that are not presently part of our conventional medicine. So we typically think of these things as what's not being followed or approved by the FDA. So these are these complementary therapies that can either be added or replaced to other therapy, and I really want to talk about more of the adjuvant role of these therapies. Just like we polled you guys before, up to 60% of patients with inflammatory bowel disease use complementary-based therapies, so this is a discussion that we should have to make sure that we're all on the same page. And these are the therapies that we talk about, and Dr. Higgins actually touched on a couple of them, but the most common is actually herbal supplements. So I'll talk to you about a couple herbal supplements, but by no means am I going to go through the exhaustive list of herbal supplements that patients can use. Alternative medical practices, so these include things like meditation, yoga, and exercise. Special diets, we're going to touch on the specific carbohydrate diet and what the data is behind that. And then others, those are the worms, the probiotics, the fecal transplants. The only thing that Dr. Higgins didn't cover was the marijuana on the other section. So we will talk about the marijuana at the end of the talk. So what are the top reasons? And I don't need to list through all of these for you, but we all have our reasons why we feel uncomfortable using traditional therapies, but these are some of the things that have been quoted, at least in the literature, is that finding a more optimal therapy, avoiding steroid-based therapies, which is actually on my list too. I don't want to use steroid-based therapies unless I absolutely have to. not being able to deal with side effects. Those things I can't control. Side effects related to conventional therapies, although they're not common, they do happen. And so if you're not able to tolerate side effects, this is one of the common things that patients cite as to why they use complementary therapy. Indirect disease benefits, taking control. I hear that a lot amongst patients, and we work a lot with our GI health psychologist. Taking control back. You know, this disease took control of your life. So having the ability to make your own decisions, you don't need a prescription for many of these therapies. And so having the ability to take control back is, I think, the most common indirect disease benefits cited reason why. And then they're considered safer, and you see that I put safer in quotes. So the issue is that most of these therapies are not regulated or approved by the Federal Drug Administration, and because of that, they're not followed very closely. And so when you see or a patient has an adverse event related to doing their own fecal transplant, they end up as a case report in the New England Journal. So the issue is that it's not being regulated, and so when you think about a lot of the drugs that Dr. Govani is going to talk about, there's thousands and thousands of patients that are being followed up. So that means thousands of patient years in terms of what we see as complications. And we can report on that. We can say 5 out of 10,000 patients that were on this therapy got tuberculosis. We can talk about that, but we can't talk about these risks because we don't know about them. And so they're often not reported. So when I say safer, I think they're presumed to be safer because they're more, quote, natural. But I don't know that we actually know that about these therapies. So I just want to make sure, because a lot of these studies that we talk about use the CDAI. The CDAI is just a fancy way to say, is this patient doing well or not doing well, and put a number to it. So as you can see, almost all of these things are based on what you tell me. How many times you're going to the bathroom? Do you have abdominal pain? Do you have symptoms outside of your bowel? Are you using anti-diarrheal drugs? Do you have a mass? Well, that's actually on me to say that. And then a couple of them are related to labs, actually just one lab, your hematocrit, which is a marker that's similar to your hemoglobin. So most of this is based on what patients say. How do they feel? So this is how we term whether patients are active or not active based on a clinical index. So this is what we use in clinic to try to make sure that we are all speaking the same language on a clinical standpoint. So I just want to make sure that you understand that this isn't driven by colonoscopy data. This is not driven by an MRI. It's not driven by a C-reactive protein in your blood, and it's not driven by a fecal calprotectin in your stool. So it doesn't tell me actually what's happening with the disease. It tells me how you're feeling. So curcumin, or turmeric. So who in the room has experience with this? A lot of people. And actually that's what we've found, is that a lot of people are using this because it's something you can find right in your own home. So this is an extract, actually, and it's a large pilot study looking at adjuvant therapy. So none of the trials that looked at this, or at least none of the studies that looked at this, were looking at it as a replacement to your IBD therapy. It was using it in addition to it. So this study was 89 patients. So when I say large, when we think of clinical trials, the clinical trials have thousands of patients. So it's large in respect to some of these more complementary therapies. And they basically had patients add it to their already previous 5-ASA-based therapies, those mesalamine therapies. 2 relapses were in the treatment group and 8 versus the mesalamine group. So that was statistically significant. And so this was a 6-month follow-up. Now, clinical trials, we follow patients out at least a year. So this was a soon follow-up, but they did see that when patients added this to their regimen in a very 90 patients, that they did have a decreased risk for recurrence, clinical recurrence of their disease. Pilot study in about 10 patients, so very, very small numbers. Some Crohn's patients felt a little bit better, and ulcerative colitis patients were able to reduce their dosing. But again, this is based on open label, meaning you're not getting a colored powder versus turmeric. You're actually, you know that you're getting it, and you're saying, I feel better when I take this. So it's not a placebo-controlled data. So we need those large, prospective, randomized, placebo-controlled trials. This is how the infliximabs and the adalimumabs of the world got approved. We need those sort of trials to see if this is really a true benefit. There's no objective follow-up in these. I'd love to see a study where we added this to our ulcerative colitis patients, and then we checked fecal calprotectins, or we did a colonoscopy to see if there was mucosal healing, to see if we can really change outcomes. So initial small studies are showing some promise. So the verdict is, I think there's a hope that this could be or have a role in adjuvant therapy. I just think we need a little bit more data to make it more sort of, to get it out into the masses. All right, so moving on to omega-3s, which is mostly fish oils, things that are found in fish, various nuts, soybean oil, dietary supplements. Many of you probably take this for other reasons outside of any possible anti-inflammatory benefits. The initial studies were really small, and they actually showed inconsistent data. So some showed improvement, some showed no difference, there really wasn't a clear evidence from that. So then they designed a trial that looked at 700 Crohn's disease patients. So this is a large trial in the complementary alternative world. 700 patients, there was no benefit. So this was placebo-controlled, so they got fish oil capsules versus placebo. There was no benefit over placebo. So what's the harm in taking fish oil? Well, there isn't really harm in taking fish oil. And there's probably a lot of benefits for other reasons, but this is not going to treat your inflammatory bowel disease. And it's not, certainly based on this large trial, going to make any difference over placebo. So if you wanted to take fish oil, I would say that that's up to you. There's really no harms, but it's not going to treat your disease. And what we worry about is patients supplementing or substituting. So you say, I'm not going to take my 5-ASA today, I'm going to take my fish oil and see what happens. That's where I worry what happens with disease and patients actually get worse. So I'm going to say it's probably hype as adjuvant therapy. But again, this isn't to say that fish oil should be banned and no one should take fish oil, but there's probably other benefits that are outside of your inflammatory bowel disease that it's helping with. So these are a whole list of therapies that I could talk for hours on that have really limited data or maybe some small data to say that there might be benefit as adjuvant therapy. And then obviously Dr. Higgins talked about all these microbiome-based therapies, and he didn't get into the Mycobacterium avium subspecies paratuberculosis vaccine, say that 10 times fast. That's really being looked at right now in Europe, and I think that we don't have enough information to say whether or not this is going to actually be what is deemed in the literature as a cure for IBD. I certainly don't think that's possible, but I do think that there may be a role in a subset of patients that have Crohn's disease that this actually might be a real treatment for them. So dietary management, hope or hype. So there's a lot of patients, I would say 100% of patients that mention diet at one point in a visit in terms of what can they do to dietary-wise to control their inflammation, what can they do to treat symptoms. So I'm going to give you a little bit of information about the elemental diet. And we actually have one of our pediatric gastroenterologists here in the room, and he probably has more experience with this than I do. And I've actually had a couple patients where we've put them on bowel rest and used an elemental diet and have been able to induce remission. But this is not a palatable diet. This is not something that you would be drinking every day, at least in the way that we think about it. There are some newer formulations that might be more palatable, but this requires a feeding tube to be placed, and not a permanent one, usually a nasogastric or a nasojejunal, which goes from the nose into the stomach or into the small intestine. And you walk around with a feeding tube, and it's not for just a couple days, it's for multiple months to induce remission, and we know that it works in children, in a subset of children, but I don't think that this is mainstream where we should be introducing this to all of our inflammatory bowel disease patients. I think that there's more data to suggest it's helpful in some of our severe pediatric Crohn's patients. So I don't think that this is mainstream, and this is really controlling all factors of the diet and putting into an elemental diet so that you basically things are right at the amino acid level. This is not proteins that you need to be breaking down. So I think that there's hope in children, but I don't know that there's much of a role for an elemental diet in adults, at least on a large scale. So we do have some patients that we use this in the adult side, but they're very carefully selected for that. So the specific carbohydrate diet, who's tried, thought about it, read about it? So not as many people as I was expecting. So this was proposed in 1924 as a management for celiac disease, and it was really popularized by the most recent book that came out, Breaking the Vicious Cycle, in terms of how it could have anti-inflammatory based properties. So without trying to simplify it, a very complex diet. It really is the avoidance of di and polysaccharide carbs. So it's really focusing on trying to take in monosaccharide carbohydrates. The idea is that these more complex carbohydrates, when they get to the colon, they interact with the bacteria and they cause mucosal injury in that way. So if you avoid those things, then you don't, then you prevent the initial cycle to begin with, hence the name of the book. But really, there's not a lot of data on it. So there's a case series that actually came out of Chicago. It was from Rush University. It was 50 patients that had self-reported. So they had said, I started the specific carbohydrate diet. The problem with self-reporting of diets is, at one point I was on a paleo diet. Now, I was paleo probably 70% of the time, but 30% of the time I was eating normal food. So that's probably the same thing that happens with a specific carbohydrate diet, is that most of the time you're eating that diet, but there's probably some variation in the diet, and it's really hard to control diets. Diet is basically 3 times a day at least that people are eating, and it's really hard to control the things unless you physically are putting it in your mouth. So if you're eating out, or if you're not eating your own cooked meals, it's hard to control for those things. But in these 50 patients that reported that they were on this diet, they did report that they went into clinical remission, so they felt better. So remember, clinical remission is just saying you're feeling better or you're not feeling better. But many were still taking their IBD therapies, which is good, but it didn't get them off their IBD therapies. So the most common reason that patients talk to me about the specific carbohydrate diet is they want to supplement their IBD therapies, or substitute is the right word, their IBD therapies with the specific carbohydrate diet. And I think that that is probably the most harmful thing that we can do, is to start transitioning therapies with diets that don't have a lot of data. Remember, there were no placebos in this, so patients just said they felt better. We didn't see any signs of mucosal healing. They weren't looking at objective markers of inflammation. So this is concerning to completely take you off therapy and put you on a specific carbohydrate diet without a lot of evidence. So I think given the lack of data on this, based on a small case series of patient-reported whether they got better or not, I think that this is more hype than it is hope right now. I want to put a plug in for the CCFA, and all of you guys here today are supporting the CCFA, is they're actually doing a big push to put more money into funding of dietary interventions or dietary supplementation in terms of how we can help our patients with Crohn's and colitis. So there are studies and there is money going into research right now, so this is something that we may have more information on in the next couple of years. Exercise and yoga. I'm going to go quickly through this. So the taking steps. You guys all probably went out for Take Steps. If you didn't, make sure you sign up next year. But we do know that in our patients with Crohn's and colitis, that getting up and walking helps you feel better. It helps with mood, and we know that it helps with osteoporosis. So even if it does nothing to your colon, which in some more animal-based models suggesting that more physically active animals might have decreased inflammation. We haven't put that out into human studies yet. If it does nothing else than make you feel better, getting up and walking is a great thing. And so I think there's a lot of data to suggest exercise as a hope to adjuvant therapy. I liked the study that was presented a couple years ago at our national conference looking at yoga. So yoga in Crohn's and colitis patients actually helps significantly with abdominal pain and joint pain, and probably helps a lot more with quality of life as well, although they didn't look at that as one of the outcomes. So if you have any of these things, exercise and yoga is definitely a good adjuvant therapy to your already current conventional therapies. All right, so the 2 last topics. So low-dose naltrexone. So what's the appeal about low-dose naltrexone? And I'll go into what it is for those of you in the room that have never heard of it. It's inexpensive. It costs about $1 a day. It's once daily oral dosing, and it doesn't have a lot of side effects. If I was somebody working in the pharmaceutical industry, this would be the perfect drug. The issue is, it sounds almost too good to be true, and it is. So the data is really lacking here. So what low-dose naltrexone or naltrexone is, it's a potent acting opioid antagonist. So when you take a pain medication like morphine or Dilaudid or any of the opioid-based pain medications, it acts the opposite of this. So basically it's acting in a different way at the receptor that would be used to modulate pain. We know that it has direct effects in GI motility itself, so that it stimulates peristalsis, it increases transit. We know that there's also these receptors on different lymphocytes. So the things that are causing inflammation, we know that there are receptors. So it sounds in theory like this should be a good drug. But what does the evidence show? So they took 17 patients, so I took all of you in this front row right here, and I had you take this medication, and then I did follow up on you. So you did follow up in terms of about 4 months. You took this drug. You knew what you were taking. There was no placebo. And 90% of you noticed that you felt better. And about 70% of you actually said that you were completely healed. You felt healed. But they didn't look at any objective markers, which I think is the main limitation of this. Well, they did look at, a few objective markers, but they didn't look for mucosal healing in these patients. And I think that's a real problem with the study, and they also didn't do a placebo control. So if we all took a pill, we could potentially feel better. And the reason why the FDA requires placebo-controlled trials to get medications approved is that there's a placebo response rate. So I think that the issue with that is and when you analyze the data, is that they use the CDAI. So there's Crohn's patients, and we ask them how they felt, and we know that the direct effects of this therapy can change things directly on the CDAI. It's what we would expect to happen. So patients felt better on low-dose naltrexone, but it did not treat their disease. There was a slight improvement in the CRP, but it wasn't statistically significant. And remember, this is an N of 17. So the front row right here, or the front 2 rows, took this therapy and felt better. So that always makes you feel good, but it didn't have an effect in terms of overall disease. The side effects were diarrhea diarrhea, abdominal pain, insomnia, nausea, and vomiting, all undesirable side effects, and probably some baseline symptoms that some of the patients had when they were already in the study, which just tells me that probably they didn't actually get better, that these weren't necessarily side effects, but more of just ongoing worsening disease. So then they did a single center randomized controlled trial in 34 patients. So they doubled the numbers from the 17. So this is randomized control. So this means that half of them got placebo and half of them got low-dose naltrexone. 60% of them had previously been on biologic-based therapy, those anti-TNF-based therapies, and most patients were continuing their regular therapy. So this was not meant to be a substitute for regular therapy. At 12 weeks, they looked at clinical response. So 83% in the low-dose naltrexone group, when they added it to their traditional therapy, had a clinical response. They felt a little bit better, but they were not completely healed, versus 40% in the placebo group. So 40% in the placebo group got better. So that's why it's important to notice what the difference is between the response rate and the placebo rate. They had endoscopic quote-unquote improvement, but they didn't actually make this a standard measure. And so the fact that this actually got published was quite shocking, because it didn't really have hard outcomes like we see in some of our clinical trials. And there was no evidence of clinical or endoscopic remission. So I would say that based on that, I'm going to jump through here. Based on the small study, remember, less than 35 patients are being studied with this. So this is not thousands and thousands of data. When we have thousands of patients with years of follow-up and standard therapy, it showed maybe some small efficacy as an adjuvant therapy. But my patients who come in who want to do this don't want to use it as an adjuvant therapy. They want to use it as a primary treatment, and I don't think that the data supports that. So I would say it's likely hype, because there's not clear evidence that this is actually of much benefit on a grand scale. All right, last but not least, and I'm gonna really, it's not being brief, but we're just gonna talk about this. So this was the cover of one of our big journals a couple years back, and this basically was saying cannabis smoking to treat Crohn's disease. And it's unfortunate, because the study that this was based on is actually a negative study, but this making the cover got everyone excited, both from a patient standpoint, but also from a provider standpoint. So cannabis sativa is the plant, and it's composed of thousands and hundreds of compounds called phytocannabinoids, THC, many of you are familiar with, and cannabidiol, or CBD. I'm going to use those throughout the talk, because if you say these two words a lot, you're going to get tongue-tied. But anyway, these cannabinoids act on endocannabinoid receptors, and these receptors are found throughout the body. They're found in the immune system, they're found in the central nervous system, so they're found on those immune cells that are causing inflammation, and they're also found within the gut. And so this is a potential very exciting therapeutic intervention. We have 2 synthetic FDA-approved cannabinoids that actually are THC-based cannabinoids, so they're not cannabidiol, and I'll talk to you a little bit about the differences. But one is, you can see those right there. Those have not been studied in ulcerative colitis of Crohn's disease, but we do use them in some patients, sort of off-label. They are not currently FDA-approved in Crohn's or colitis. So what are the effects, the clinical effects of cannabinoids? So not just cannabis in general, but of cannabinoids. So we know that it improves sleep. We know that it's an antiemetic in multiple trials, not just in Crohn's and colitis, but it's actually FDA approved, the synthetic ones, for chemotherapy-induced nausea and vomiting. We know it stimulates appetite, and we know it relieves pain. And there may be some mechanism to decrease diarrhea, although in the current form it's been studied, it hasn't really shown this as a direct effect. So what's the timeline? How did marijuana come about, or how did cannabis come about in terms of getting legalized? So a very, very long time ago, it was written in the Chinese medicine literature. In the mid-1800s, there's a little bit of a debate in the literature whether it was an Irish physician or Mexican immigrants who brought it over to the United States. But either way, both take credit. In 1850, they put it in U.S. Pharmacopoeia. So this was, at that time, the sort of the end-all be-all of medicines in terms of their effects. In the early 1900s, so about 100 years ago, they were able to define the endocannabinoid system. So while many years ago, they knew all of this, that there potentially were effects, they didn't know why those effects were happening until the last 100 years. And then the Controlled Substance Act made it a Schedule I substance, so made it illegal for both recreational and medical use in 1971. And if you can believe it, 20 years ago, California was the first state to legalize it for medical purposes. I gave this talk to providers, or a similar talk about cannabis and the role of cannabis in IBD, about 18 months ago, and this was what the map looked like in terms of medical legal is the the dark green, and then legal for recreational use. So this is Colorado and Alaska, Washington, and Oregon that have legalized it for recreational use. And then we can see the map has changed significantly. So there's a lot of legislation going on in terms of changing this landscape. So there's only about 8 states that have no laws at all about medical or recreational cannabis. But full legal is still those same 4 states. Medical legal are these darker green, and then CBD medical. So there's been states that say, you know what, I think there's a benefit to medical marijuana, but it really should be in the form of a high CBD, which is the high cannabidiol to THC ratio. So THC is where patients get that euphoria or the quote-unquote high, whereas cannabidiol is actually where the direct probably medical benefits come from. So there are states that have said, we're going to jump on board, but we're really going to focus on that high cannabidiol strain type of cannabis. But the disclaimer is that this is still a Scheduled 1. And so because of that status, it can't be studied. It can't be studied with national or federal funding. It's hard to get trials going on medicinal cannabis unless they're observational studies. So in the state of Michigan, because it's approved, we can say, okay, these 50 patients that use medical marijuana, here's their outcomes. But it's hard to study it in a randomized controlled trial because it's not federally legal. So it does make the data a little bit sparse because of the legality issues. So are they using marijuana? So looking at studies, so in Canada they seem to be using it a little bit more than in Spain, but about 10%, 10 to 15% of patients are using medical marijuana. About 50% had prior use. So that's why I said I was a little bit surprised by that, is that it's about in line with current users, but past users seem to be more in Canada. The concerning thing that came out of Canada in the same group that published the use information right here, who said about 15% were using, when they followed patients up who were cannabis users over a 6-month period, they found that if you were a user, you were more likely, significantly more likely to require surgery. And that's concerning, right? That's a bad outcome from your disease. The problem is that maybe these patients had severe disease to begin with, and the reason why they were using the marijuana was to control symptoms, and it wasn't controlling their symptoms, so they progressed to surgery as either way. But I think what some of us read into this was that maybe there was a risk of disease progression and not actually helping disease as these patients went to surgery. So a study that was done out of Boston, and then as well as a study that we did at Chicago, was looking at, why do people use and what does it help? So as you can see here is about 12%. So it's in line with that 10 to 15% of patients were current users, about 40% were past users. But in terms of abdominal pain, 74%, so 50% more than the ineffective rate, had improvement in their symptoms. About 50-50 on the diarrhea. There was significant improvement in appetite, and there was significant improvement in nausea. So I think that the role for medical marijuana as an adjuvant therapy more falls in line with symptom control than it does with inflammatory control. So where's the role for medical marijuana and IBD? So some small observational studies showed that patients overall felt better, and they had decreased need for steroids as well as symptom improvement. But the study that my patients quote when they come in wanting to switch off therapy and start medical marijuana is the Naftali study that was out of Israel. So obviously we couldn't study it here because of the status of the drug. So the Israeli study was done in 21 patients. So the N is really, really small. They took patients with moderate to severe Crohn's disease. So these are our sicker Crohn's patients, and they had been on a whole host of type of therapies, and they randomized to smoke either placebo or cannabis. So one of the issues with the study is it's hard to make placebo smoked cannabis because you obviously get the effects of THC. So it's hard to say that this is truly a placebo-controlled trial in that sense, but just giving you the data that exists. So overall, based on what they say, is that there was evidence of clinical response. So this chart that I show you is the data. So in the study population that smoked marijuana, 45% were able to go into clinical remission. So clinical remission, there wasn't any endoscopic improvement because they didn't look, and there wasn't an improvement in C-reactive protein or hemoglobin, which they did look at. And the placebo group, 10% were able to go into remission. But remember, it's hard to do a placebo-controlled trial when there's THC involved because of that euphoria. The mean score went down in both groups, and then the clinical response was also seen greater in the study group. But when I say it's a negative study, I want you guys to focus. So many of you probably aren't aware of p-value. So p-value is how we say is something by chance, or is it actually clinically significant? So the issue is that with a p-value like this, it says that this could have possibly happened by chance. And it actually almost 50% chance that it happened by chance. So it's a negative study. It didn't really show a difference between the two groups. And then when all of the patients stopped using, they all had relapse of their symptoms. So when we look for medical therapies, we want durable response. We don't want you to only be well when you're taking the therapy. We want you to continue taking the therapy, but if you were to stop the therapy for a couple of days, we don't necessarily think that you should have a relapse in symptoms because we want a durable response to the therapy. So it didn't seem to have that effect either. There's still so many unanswered questions, and I list them all here. But basically, does the strain matter? How you take it, does that matter? We don't have any high quality controlled trials because right now the way that the federal government has made it a class 1, we can't study the medication. I think a lot of the researchers that are up here and throughout the country would like to be able to study this. I think that there might be some role in terms of adjuvant therapy for our patients, but we just don't have the data. And then what are the long-term outcomes that happen with patients who use cannabis. And so what I'm going to touch briefly on is, can it be harmful? So if patients say, well, maybe it doesn't help that much, is it going to hurt me if I use cannabis on a daily basis? Well, it overall has a pretty good safety profile. The acute adverse events, so right when you're using cannabis, whether it's being smoked or oral intake, is anxiety and psychotic symptoms. So I can imagine some patients in the room that have underlying anxiety, this might not be a good therapy for you. Chronic adverse events, so it isn't increased risk of motor vehicle accidents, that has been shown. Decreased risk of fertility, especially in men. There's been some literature to suggest that it decreases the development in younger patients that are using it. Chronic inhalation effects, so obviously smoking high temperatures of smoke is probably not good for your lungs, and some data suggest it might increase your risk for lung cancer. Withdrawal symptoms if you don't use it. And then one of the biggest things is that there have not been any deaths associated with it, which is good news. But one of the things that I see very commonly in my practice is cannabis hyperemesis syndrome. This is a pretty miserable syndrome. Patients are really, really sick. They can't eat, they can't drink, and it's directly related to cannabis use. And if they stop using cannabis, the syndrome goes away, which is good news. But it's not that it goes away the next day. It takes some time. In addition, this can have a significant impact on your quality of life if you do develop this. So while the benefit may be kind of questionable, there are some risks, at least in terms of how you feel with daily cannabis use. But what I and most of my colleagues are most concerned about is the study that came out from the same people that published that trial in Israel that showed that when patients started using cannabis, they stopped their medical therapies. And that's what worries me the most about medical marijuana, is that people use it as a substitute to effective medical therapies. So look at this. Patients stopped their therapies. It doesn't mean that they stayed well. It just means that they physically stopped them. So patients on anti-TNF, these biologic-based therapies that potentially be harmful in some situations if we put you back on them or you wouldn't respond, a good percentage of the patients stop their therapies. So I just want to point out that this is what the real dangers are to medical marijuana and IBD, is that the risk of patients stopping therapies because they do feel better. They have less nausea, they have less pain, they're sleeping better at night, and they feel like, I'm better, so I'm going to stop my medical therapy. So this is what I get most concerned about. So the bottom line is that we don't have enough evidence right now. There might, and I underline might, be a role for adjuvant therapy in a select patient with Crohn's disease. It has not been looked at in patients with ulcerative colitis. So I think that there's hope for adjuvant therapy, but I just don't think we have enough information right now. So I think overall, we have some data to suggest that there might be hope for a lot of these adjuvant therapies, a lot of these alternative therapies as adjuvant therapies, so you're already effective, or maybe not as effective as you'd like them to be, traditional therapies. So if you have some of the symptoms that we talked about, maybe there's a role in adding some of these adjuvant therapies to that. But it's important that you work with your provider in terms of discussing the risks and benefits of some of these adjuvant-based therapies. And then a quick plug for a clinical trial. So those of you in the room that have Crohn's disease and maybe not be in complete clinical remission, if you have ongoing symptoms, we are going to have a synthetic cannabinoid that's going to be coming to the University of Michigan. It's an 8-week open label, meaning everybody gets drug for 8 weeks, and then we see how you do. So this is a potential if you have some ongoing symptoms and you have Crohn's disease. This is the email that you can email right here in terms of getting screened for this study that's going to be coming up in the next couple months. So if you were interested in cannabinoids or you wanted to participate to get more evidence on this, this is a synthetic version, so it's a pill. Thank you very much. I've done this talk with Christina Ha from UCLA, as well as Eric Berlin, who's one of the lawyers who's responsible for a lot of the litigation that's happened nationally in terms of getting this medication available, or I'm sorry, this medical therapy of cannabis available to patients from medical use. So I've worked with them very closely, and I appreciate their input into this talk. And I'm happy to take any quick questions, or maybe Ryan's going to cut me off because I went a little long. I apologize for that.
Thank you, Dr.
Thank
Kinnucan.
you.
What a tour de force, huh? Okay. I think that's all you need to know. We can close now and go home, right? Any questions? I think we have one right here.
Can you elaborate on gluten in dairy and how it affects colitis?
Yeah, absolutely. So we don't have a lot of data in terms of the effects on colitis. We do know that that gluten in dairy can increase symptoms. So that's where the CCFA is putting a lot of money, is to actually look at the effects of gluten on inflammatory bowel disease, inflammation. So I do have a lot of patients that go gluten-free because it increases their symptoms, but we don't have any data to suggest that gluten itself has a direct impact on inflammation. So I think you should stay tuned, because there's going to be some more information coming. It's really hard to study gluten-free diet in colitis patients in a randomized fashion, and to try to weed out all of the things that can confound the results. So I think there's going to be more data coming, and I know that that's a big popular topic with a lot of my patients.
We have time for one more quick question.
I do not use cannabis. I've thought about it, but after many years of having Crohn's/colitis, I know that almost all my flare-ups came from stress. Now, a lot of the things you talked about with regard to cannabis were metabolic reactions to cannabis. Is there any evidence to relieving stress, that euphoria, and helping with the psychological part of it?
Yeah, so that's also a really hard thing to study, right? Because we all perceive stress differently. So yes, I think that stress, and I think that there is an impact in the work that I've done from research, is looking at sleep disturbances, which directly affects daytime issues with stress or perceived fatigue. There is definitely a metabolic role in terms of that communication. We just don't have a lot of data to say if everyone was stress-free, your disease would be perfect. Because there's plenty of times that you have flares of your disease when you say, I'm feeling the best I've ever felt, I've got a job, I've married, where you don't have any perceived stress and you have inflammation. So it's a really hard thing to study. We do know that yoga and exercise make you feel better, and whether they have effects on your inflammation, I think, are yet to be seen. But that's a really excellent question. Yeah. Awesome. Thank you guys for your attention. I appreciate it.
Great. Thank you very much, Jamie.